I'm Roger Baker, Executive Director of the Stratfor Center for Applied Geopolitics at RANE, a global center of excellence for geopolitical intelligence and analysis. Learn how you can put geopolitics to work for your organization at ranenetwork.com.
Welcome to the RANE Insights podcast from RANE Network. In this episode, founder of RANE, David Lawrence, sits down with Dr. Mark Gold for part 4 of their discussion on the United States of addiction, dealing with the opioid crisis in the medical community and beyond. Dr. Mark Gold is an author, inventor, mentor, and world-renowned expert on addiction-related diseases. Dr. Gold has had over 1,000 peer-reviewed publications since beginning his academic career at the University of Florida College of Medicine and Yale University School of Medicine in the 1970s. Dr. Gold has modernized addiction and psychiatric training, fellowship, and treatment programs while hopeful that research would translate into new, more effective treatments. Check out Dr. Mark Gold's full bio and host of written publications at psychologytoday.com. We hope you enjoy this episode.
Mark, again, thanks for making time, and I'm very much looking forward to this conversation because you wrote an absolutely terrific article for Psychology Today, which I took as an invitation to rethink our prevention strategy around drugs in general, opioids, fentanyl, etc. And you draw lessons from the anti-smoking, anti-cigarette campaign. And with the new administration coming in, there's always an opportunity to take a fresh look at what we've been doing, because it hasn't been working, and to see if there's some things we can do that might be better. So maybe I'll just give you the floor and you can talk about the inspiration for that article, why you wrote it, and just, share with the audience some of the insights that you want to share about what we could do better, quite frankly. That was my takeaway from the great article.
Thanks. I appreciate you and the audience very much. And I just wanted to take the time to make sure everyone was on the same page. And maybe we didn't take enough credit in the public health community and the prevention community for the tremendous progress we've made with cigarette smoking in the United States. So I restated, in the 60s, which you might remember, 50% of all United States adults smoked cigarettes. And that number is down to about 12% and decreasing. So you might say, how did we do that? And can't we learn from that? And why is it I haven't heard anything or very little about prevention at all in the midst of this opioid crisis? How come I haven't been inundated with messages about how dangerous opioids are or how dangerous fentanyl is? So the first question would be, did we decrease the number of smokers because we invented treatments? Well, I'm an inventor, and I helped develop some treatments that are used in smokers. But if you took the patch and the gum and the inhaler and the oral pills for smoking cessation, their contribution was actually pretty small. They did provide people with quit attempts, but what prevented relapses is really the public information about smoking. Like, think about what public information it might be. Well, we had ads about smoking. Brooke Shields had ads. The American Cancer Association had ads. Rob Reiner in the state of California had ads. And so we went from you remember that TV show Mad Men? All the adults smoking, they smoked at work. Well, when I was in medical school, my teachers smoked, doctors smoked. We had a non-smoking section of my medical school class. That's about as ridiculous as a non-smoking section of an airplane. Well, still the smoke traveled, still you got secondhand smoke, still you got cancer risks, and so harm reduction as applied to cigarette smoking was a non-starter. We tried that. We basically had patch and gum, which might be equivalent to methadone, and we had pharmacological treatments, which in some sense could be thought of as related to medical treatments for cigarette smoking. But by and large, the big impact was made by changing the way people thought about tobacco, nicotine dependence or tobacco addiction, and the dangers of secondhand smoke. It started with the Surgeon General's report, which was in the mid-60s, and then it moved on to warning labels on cigarettes. It moved on to no TV commercials related to cigarettes. But the big things in your field, David, was public health laws. Like guys like me showed that secondhand smoke was firsthand smoke without consent, meaning that you could get addicted to secondhand smoke. You could have brain changes from living in a smoking environment and claim you don't smoke, but in fact your brain changes as if you smoked. And we even showed that you could get cigarette withdrawal in non-smokers if they grew up in households with smokers. But so that lawyers and public health advocates said, well, secondhand smoke is a danger for non-smokers, and then they passed all these laws. You can't smoke in an airplane. You can't smoke in the workplace. You know, and Henry Ford was famous for giving out tobacco, cigarettes, for free to workers early on in the assembly line, saying it reduced error rate. And we gave cigarettes to sentries in the military, again, to keep them up at night and reduce their distractibility. We eliminated smoking in restaurants and public spaces, and I remember people having to smoke outside, like by exhaust vents, because it was so cold in Washington, D.C. or New York City. And there were people saying, well, that's terrible. You're stigmatizing cigarette smoking. And I think as long as you didn't stigmatize cigarette smokers, stigmatizing cigarette smoking made sense. But we did go farther and stigmatize cigarette smokers. There's non-smoking health insurance rates. There's non-smoking life insurance rates. Cigarette smokers were identified in the medical chart and asked each visit to the doctor whether they were ready to quit now. Did they need some help pharmacologically or otherwise quitting? And so we changed from a Mad Max, everybody smoking, harm mitigation, to being smoke-free was healthy, recognizing it's healthy and normalize that, and while encouraging people to quit. So I reviewed all of the past successes. I didn't go into all the details on the advertising, but toward the end, the cigarettes, it was hard to avoid even a child saying to a parent, please stop smoking because you're going to die. And that was as a result of smoking education and prevention activities in the classroom. None of that, by the way, has been happening in the fentanyl epidemic, which I point out in the article. We've lost at least 500,000 people, and the death toll from fentanyl exceeds all of the U.S. deaths from Vietnam plus Korean Wars combined. So we're near Veterans Day, and you think about all the tragic loss and sacrifice, and we're going through this right now, and it just doesn't seem like we have the same outrage and alarm.
I'm glad you used the word outrage, Mark, because I know we've discussed this before, and it was reflected in your article. But this is the thing that I think many, many people find so troubling, and particularly the families that have lost loved ones, that this is not, for a variety of reasons, attracted the attention, and or the concerted effort to deal with this as a significant ongoing, not only medical healthcare issue, but mental healthcare issue. And so I'm so glad you made those points, but we just don't seem to have the political will. And I was going to throw something in. Obviously, I didn't have advance notice of your article. But one of the significant aspects in garnering, we'll call it the support for the campaigns, et cetera, you had a plaintiff's bar that went after the tobacco companies. And you'll recall this was not over in a couple of years, it's many decades, and there were issues about the addictive quality of tobacco, et cetera. But it wasn't until significant sums of money, and the states joined the plaintiffs' bar, that seemed to be allocated, that we started these campaigns. And we started these healthcare initiatives, and I'll credit, Mayor Bloomberg, and, was fortunate, he has significant assets, which he put behind the issue of smoking and secondhand smoking and the research and things. But, a number of things came together around the tobacco problem that just don't seem present. And what is, I'm glad you used the word, again, outrage, because the number of deaths, and they're recurring. I mean, these every year it starts again. And it's even more tragic because these are people who are passing away who are not in their 50s or 60s or 70s. These are very, very young people who haven't even hit the prime of their life. And still we haven't had that concerted action and response. And, so my question to you, Mark, because you've been in the game for a long, long time, is this simply a matter of someone recognizing we have to try something new and adopt some of the same techniques, or is there something greater that needs to happen here in terms of political focus?
It's like everything, it's complicated, and like everything, the lawyers and public health people do a better job than I do. I mean, I'm good at finding new treatments and thinking in a new way, but how you would make change, I could only make suggestions. So on some of these, I do think the medical model has limitations. Inventing a treatment for tobacco smoking cessation or relapse prevention doesn't cure or end the tobacco epidemic. Why would methadone or buprenorphine or naltrexone or naloxone end the opioid epidemic? We don't have reason to believe that to be the case. Secondly, there are things that are missing. Like, it's very important to destigmatize being a person with opioid use disorder because we want them to enter treatment. But we have to realize that most people who enter treatment relapse and relapse multiple times. One of my colleagues, who's now deceased, did a study where he looked at people who entered treatment for opioid use disorder, and he was finding people who had been in treatment 15 times, who overdosed multiple times, and who were rescued multiple times. It's not like these treatments provide cures. They're treatments that are very essential, like in tobacco treatments, but they're not going to change the face of the drug epidemic. I looked at what's the danger in making it seem ridiculously dangerous, like Russian roulette, to use fentanyl or an opioid recreationally. Why is it not clear to people that illegal opioid use is a fast track to family tragedy? And so when I said that, one of the people helping me looked at the article, and who's an expert in the field, been in the field even longer than I have. He said, well, could you prove that if somebody asked? Well, in fact, there's a recent article that says 321,566 American children have been orphaned by overdose just between 2011 and 2021. Like, well, what other data do you need to say that if you use fentanyl or opioids, you join the risk group from which tragedy is likely to occur and from which opioid use disorder is likely to be chosen? So I do think we have two separate things at work. One is the evergreen phenomenon that we're seeing, which is that no matter how many people die, 100,000 people die, and you would think that would mean less people would die the next year. We're at 500,000 now. Obviously, we are a recurring nightmare, even with naloxone, even with naloxone reversal. Why? Because naloxone reversal is not always followed by treatment initiation, and treatment initiation is not compelled, and treatment continuation is generally much less than people consider. So if you take the medical model and reduce it to its absurd, it would be, well, people who have opioid use disorder have diabetes. Well, then why would they stop their insulin? Because they're going to relapse and have a tragedy if they don't continue on their methadone or buprenorphine. Anyway, I just think that some of the states and cities are making new changes that should help. Like, who would have ever thought that it would have been offensive to tell people that they can't use drugs in public? Like, you can't inject drugs in public. You can't smoke crack in public. Why should children be traumatized by this occurrence of walking past people who are overdosing, people who are semi-conscious, or if you happen to be in a city with xylazine, people who look like zombies? These are not experiences that I believe we need to share, and to me are like secondhand smoke, where the opioid user is causing damage to this other people, as well as the focus has been on damage to the city they live in, on commerce, but I think the damage occurs to everybody that walks by them. I'm a trained doctor. I gave people naloxone in the early to mid 70s at Yale, and resuscitating a person who's overdosed is great. It's life-saving, but I can't tell you how many times I've rescued someone where they were not appreciative, where they said they were just sleeping or dreaming, or I ruined their high. Yes, it's true that naloxone availability will reduce the overdose death. That death, you can help a person, but that's really just the first step. So I think we need to prevent the evergreen phenomenon by preventing new use. And we can learn a lot from tobacco, and we can learn a lot from the successes in public health campaigns and in stigmatizing tobacco use. We can learn a lot to reduce the flow of new users in. And then for the people who are rescued, do have loss of control due to opioids, we need to figure out how to get them into treatment. And how I know in the state of Florida, if you're a physician who overdoses in the on-call room, let's say, we do an intervention, and we tell the physician that they're going to get treatment and follow this specific treatment plan for 5 years, or else they're not going to practice medicine in Florida. That's coercive treatment. It's in essence involuntary treatment. It's like an intervention with family members saying, this and that. So people who we rescue, we have to do more to help reduce their relapse rate and take them out of this never-ending cycle of overdose, slip, relapse, increasing health problems, and then over time it becomes nihilism. And as one of the Harvard researchers showed, if you interview people who've had these kinds of overdoses after they've been rescued, a high percent of them say they wouldn't have minded it if they would have just died and gotten it over with.
Okay. So you pointed out certain things we did effectively with cigarettes and tobacco, but you've also highlighted a number of differences in the nature of the problem. And one of them has to do with when somebody is addicted, it's, first of all, the ability to reason with them. The addiction is essentially involuntary. It takes over, and it's very difficult, and there's no medical magic wand. You also highlighted, just with that last tale, that people who overdose sometimes regret that they have recovered from it. And I don't recall similar situations with people who had a bad cancer scare with, from smoking with tobacco. Although, Mark, you'll recall they had pictures of people who, had lung surgery, and they're taking in the nicotine. It's so addictive. They're taking it through the I guess they had a tracheotomy. But they're still smoking.
Right.
But you also highlighted the point about stigma, and I may be wrong in this, but you and I lived through the reversal of social acceptance in smoking. It's hard for many people in our audience to remember this, but there was a time we got on an airplane, and half the airplane was you were allowed to smoke, and the other half was not smoking. Right?
Yeah, no, the lawyers did a great job. They actually, there were a lot of suits related to that, but it was the stupidest thing. Like my medical school class, the idea they had ashtrays set up in half the class,
Right.
like because
the smoking
that was
section in the
harm
big
reduction.
hall, right? You could smoke in some places, but you highlighted the issue of stigma, and I can't recall ever that my friends who smoked, they were stigmatized or ostracized, and yet the people, and this, the families feel this when they have loved ones who have become addicted. They worry about the stigma of this, okay? And I know you've spent a lot of time trying to remove that stigma and to treat this as a disease, and a disease that, once somebody becomes addicted and the disorder sets in, it's very, very hard to break the cycle. So as you think about the messaging and the effectiveness of the anti-smoking campaign, I'd love to get your thoughts about incorporating, if you feel it's necessary, this message of destigmatizing, because look, young people, they take risks, they make choices, and then, you really get addicted and it gets held on. And just apropos that, I don't want to get too far afield, but I've listened to interviews of young people who've gotten addicted to vaping.
Right.
And so but they're not going to be ostracized. They're not going to be stigmatized. They're not going to be threatened with jail,
Right.
et cetera. And so, talk to me a little bit about the message
yeah, I
that
mean,
you
I
would
think
like to see. Yeah.
that's the kind of fine line that I tried to thread the needle here. Like, can you stigmatize fentanyl? Can you stigmatize intravenous use of fentanyl? Can you stigmatize opioid use without stigmatizing the person who's using? Can you hate the sin and love the sinner? My answer is yes. So, but I don't think that you can waste time pretending that these drugs are not doing what they're doing to families and people every day. It's a national catastrophe. And the idea that we haven't villainized drug use, villainized opioid use, is just a part of the problem right now. We've done a great job on improving the workforce for addiction medicine. We have more doctors who can prescribe life-saving medications than ever. We've done a good job of getting naloxone out there. It's all over the place. EMTs, emergency rooms, people who love someone who has an opioid use disorder. We've done a great job on that. We've done a good job of educating communities about things they can do. But these are all medical things. It would be, again, in the smoking analogy, like widespread distribution of the patch or gum or treatments. It's without the social change that enables new users to come on year after year, that supports the myth that there is such a thing as people who use opioids. Like, I've heard that term used to be the ultimate in destigmatizing language, rather than opioid addicts, rather than addiction, rather than opioid use disorder. Why don't we call it people who use opioids? And I've said to my colleagues who propose this, that's ridiculous unless it's people who have to use opioids, people who've lost control over drugs. And that, in essence, is the same definition as addiction. I just don't see the reason to spend a lot of time on this right now. The time and energy for me would be spent preventing the next person from trying an opioid or injecting themselves with drugs or mixing and smoking fentanyl. I would see the harm to the person, the harm to the community, the harm to their family, and the harm to just passers-by, traumatized by what they're seeing every day in cities as enough. We should be able to say that's enough and do something about it right now. Bob DuPont, who you probably remember, is because he worked in our era, and he was the founding director of NIDA and also the first drug czar, a Democrat who worked in a Republican administration. He told me for this blog something that I think we could play with a little bit more too. He said, the killer fact in overdose prevention is this: most individuals who die of an overdose have serious substance use problems. They know about the reality of the overdose epidemic. Many have experienced non-fatal overdoses, and many have friends who have died, and yet they pay for their fatal dose of drugs. They pay themselves with their own money. No policy will slow the drug supply unless we can figure out how to stop the flow of money from drug users to drug dealers. And that, again, is a mission for the DEA. And in addition to the emphasis that we had in the smoking epidemic, public health information, stigmatize tobacco, protect the non-user, we then had the ability to raise prices. That was taxation. I remember when cigarette pack was 25 cents for a pack, and you could buy it in a vending machine. So you had teens being able to buy it, anyone, for 25 cents. You add taxes in, and you're in the $8 to $12 a pack. It's a huge difference, and the price per pack changes the total number of cigarettes smoked a day. Well, the DEA needs help and funding to raise the price per pack, raise the price per dose of fentanyl. And how they would do how they would do that is financial. They have to be able to interdict, change the game so that they reduce precursors, they reduce the flow of drugs into Mexico and across borders, and they develop ways of interfering with the kind of cryptocurrency and sophisticated financing network that enables destitute, intravenous, and other drug addicts from supporting these networks, cartels that supply them with drugs. If there wasn't a profit in it for them, they would do something else for sure.
So you've highlighted I'll call it the traditional themes around the war on drugs. And if I were going to ask you, Mark, or let's do it this way, new administration, you're asked to come to the White House. And Mark, we have to get a better communications policy together. Tell me how you would think about it. I'll make a couple points about the cigarettes. Obviously, a number of the messengers mattered. At some point, you had celebrities who were telling people not to smoke and telling kids not to smoke.
Right.
You also had what I'll refer to as a different strategy. Part of it was, this is what happens to you when you do smoke eventually. Right. I haven't seen that, either one. And this may sound a bit naive, but because young people are fearless, and you've done a great presentation about the development of, the brain and its appreciation for risk, Mark. The thing about this, even more so than tobacco, is just how quickly people can become dependent. And so give us the cornerstones of what your new outreach communications policy would look and sound like.
So, I'm not prepared to answer that, and you could do this better than I can. You're a brilliant guy, and your group does this on a individual level with companies and leaders. For me, it starts with the tone. Like, I would be screaming, I can't take it anymore. And I can't personally take it anymore. The 500,000 people have died, and we don't know their names. Every one of these deaths, again, are not there. They're really not necessary, and they shouldn't die in vain. We should be much more serious about how outrageous this is. It isn't a research enterprise. The National Institute on Drug Abuse has done a fantastic job of framing the question in terms of how can we save the most lives possible in the shortest period of time. And there are scientific projects that they funded using AI and looking at the tools available. And I've summarized them in the past, but they have shown that you can save large numbers of people by reversing overdose. Of course, that makes sense. And you can save people by giving them evidence-based treatments, so-called medication-assisted treatments like methadone, like naltrexone, like buprenorphine, and keeping them on it. That is good for where it is, but we have to do a lot better. And I do think you'll maybe even remember the extreme of prevention messages for tobacco was at the time of her maximum impact. Brooke Shields did tobacco ads where she would see, she said, I'd see a person and I'd think that I might like to go out with them, and then I'd smell tobacco on them and say, I'm not going out with them.
Unattractive, right?
Yeah. And it was more they were disgusted by this person's behavior. And that might be extreme and might overly stigmatize people, but to say we have to let people inject themselves in the street, that there was even a pushback on showing on the news the zombie drug abuse issue with xylazine plus fentanyl in Philadelphia, where people were getting necrotic lesions and some needed amputations even while they were falling over in the street. You would think that that wouldn't be very attractive to follow. And I do think the networks that did show that and did get that message out did the kinds of prevention that we're used to seeing in the tobacco epidemic, rather than what we see on the streets, which is people in tents, people on the street, injecting themselves with drugs, smoking crack, smoking fentanyl plus methamphetamine, acting under the influence and tormenting non-using citizens. For young people, I would remind everyone that there's a cadre of young people who are not using anything. And I summarized this in a past blog, but it's substantial. Over 20% of the young people in the Monitoring the Future survey are now saying they're disgusted with everything and they're not using anything.
That includes alcohol
yes,
as well.
Alcohol, tobacco, cannabis. And so I do think they're a great hope for us, but you haven't really even heard anybody reinforce that and say, isn't that great? We'll have a generation of people who will actually be able to think as well and learn as well as the Chinese, rather than having a generation that's increasingly incapable of learning new material and performing at their optimal.
Yeah, and I know you've spoken about this, Mark, but in just a couple of minutes we have left. You're speaking about this also as a geopolitical issue. And I don't mean that solely in terms of, where some of the supplies, the precursor materials and things like that are coming from. But this is a national security issue for the United States. Not in the way most people think, but you have highlighted the threat to our young people, our future generations. I mean, that's what this country is dependent upon. And to the extent that we're losing 500,000 people at a clip, 50,000 people here, 50,000 there, and each year, there's a new group of people who come up and are exposed and succumb. This is a significant national security issue for this country. We are losing, there's personal loss, but the loss of talent and potential is profound.
Yeah. It's not like 4 years of substance use is like going to college. The only learning is bad learning. Like let me just kind of put that in perspective for you, just because I'm the older guy in the room here. I went to Woodstock, and David Smith, a friend of mine who started the Haight-Ashbury Free Clinic, had a tent there. And overdose deaths were rare in the 60s. When naloxone was invented, they didn't really even think there was a market for it. It was like an orphan drug. There were so few opioid overdoses. And in fact, the pharmaceutical company decided that the way to get a market for the drug was to have anesthesiologists carry it with them for surgery to reverse respiratory depression anytime they were giving somebody opioids. So overdose deaths were rare in the 60s. In the 70s, We had, the Vietnam War and heroin. But again, overdose deaths were rare. Most of the time, much less than 10,000 per year. Say what you will about the Reagan era, we had very, very few opioid overdose or other overdose deaths. By 2009, overdose deaths tripled to 30,000. So that's just in a short period of time from the 1990s. Then the opioid crisis comes in, and now we double again to 70,000 in 2010, and nobody thought it could possibly get worse, but then again it is worse. 2023, we have 107,500 people die of drug overdoses. Now, I had a table, but I took it out of the last article, comparing us to other countries. And, to talk about like what I probably should do this one time on a podcast, but you could get a drug historian to do this just as well. We have more drug overdoses than the rest of the world put together. It is like that, the sound of silence. And, we'll say, well, China has no drug overdoses because they have corporal punishment related to drugs. You're a drug dealer, that's an approach that doesn't work in a free society. But also what doesn't work is not doing anything to stop the continuing evergreen phenomena of every year assuming that we should have 70,000+ overdoses. We should have no overdoses, but if we fail at that, we should still be able to get back to where we were in the 1970s.
That statistic was amazing, that we eclipse every other country in the world, Mark. Okay, and I don't want to let that go by.
Yeah, no, I think there's a per capita analysis where, obviously, on a per capita basis, we're still number one by a wide margin. But then some of the smaller countries that do have overdoses but less population, and then again, I'll say that our numbers are likely understated. So there's some suicides that are overdoses in reality. There are many accidents that are overdoses in reality. Right. And we don't have a system that can classify every cause of death, because they tend to be done at the local coroner level.
And we talked about the lagging statistics in this area, which is shameful.
Yeah. But even what you and I were talking about, the kind of opinion polling, like when you're outside of addiction, you can't think like an addict. So I'll give you another example. Someone looked at what happens when you give cocaine addicts pipes and paraphernalia as part of a strategy to help them. Some people take those as they're meant, as ways to continue to use, but to use safely. But there are others that sold them for money to buy crack. This doesn't surprise me because, again, if you rescue somebody and you just sat over their body, they're lifeless, they have no pulse, no respirations, and you give them Narcan and they wake up and they yell at you, you have to say to yourself, their understanding and appreciation for reality and yours are very different. And it would be good to know what they think when they see vending machines or when there are all kinds of well-intentioned, and I'm on the side of the continuous do-gooding, but it would be good to know on the evidence basis what would actually help people reduce illness but get into treatment.
Okay, and you're highlighting essentially, and this is something that people who are in marketing for a living will tell you,
Yeah.
you're highlighting the consumer perspective on the issue. And
Yeah, I'm in. People have talked about like safe areas or places where people could inject drugs. I've always looked at that as like a cigarette smoking room. You know what I mean? Like that doesn't bother me. Get them off the streets and in a safe area. That's not. I think these kind of open air drug markets are not what we're looking for. We're looking for ways to help people not overdose, take medications for their opioid use disorder, stay on them, and develop skills that they can use to live independently.
no less, as you point out with your article about tobacco, the message that prevents the problem in the first place or catches it early enough.
Right.
And for families to know where to go and where to turn. People knew there was gum you could chew, patches you could put on, support groups, right, the whole thing. We don't yet have those models. So, Mark, I'm going to take this conversation one step in closing. I'm going to make sure that some of the people who will be potentially leading in the next 4 years have heard these perspectives, because I agree there's more to be done. We've learned a lot along the way, and there's, it's really owed to the citizens of this country to do a better job on this.
Yeah, you can't expect like the research establishment to solve this problem.
Right.
Like when I think about NIDA, like they funded somebody who's inventing a vaccine against fentanyl, for God's sakes. That's amazing. But again, somebody would need to take it. Then they'd need to repeat to take it. But like the science side of this has been brilliant. And you and I spoke, there's some of the psychedelics that will have an effect. But bottom line, at the end of the day, the medical treatments, the invention of them, the use of them have a limited impact. But we do know that we succeeded with one of the world's most addicting drugs. We can do this again.
An important tool in the toolbox, but other tools are needed here, not to be cliched about it. All right, so Mark, we're going to make sure we post the terrific article that you wrote. Also, David Mark has referred to some of the prior articles. David's our producer. We'll get those up as well. And we'll continue the conversation in a couple of weeks, Mark. So thank you very, very much again for your continued, I'll call it public speaking and sharing of the insights that you've gained over the many decades that you've been at this. So very few people has experienced. So I got to ask, do you feel like Sisyphus sometimes?
I love that myth of Sisyphus, that was one of my favorite books.
Yeah.
But no, what I feel like is I have to stay in my lane. Like, you can't solve a big problem like this yourself. I'm not young enough to prove that secondhand smoke is addicting, which or develop new treatments for opioid use disorder, or work on the dopamine hypothesis for cocaine. Those are young man's 10 years at a time, my career in research. But I do think I have some pattern recognition.
Mark, I think not only you have pattern recognition, but this is what I will also say is you have acquired wisdom, and this stuff, at some point you got to feel like you're living in the book of Ecclesiastes. It's all been said and done before. You're watching the
Well,
waves of this come back and back and back, and people have the expression of doing the same thing over and over again, expect a
Right.
different result. We've got to
Right.
change it up. Anyway, Mark,
Thanks
thank
so
you
much.
as always for the time.
Thank you.
Truly.
Appreciate you guys.
Very precious. Okay, thanks.
Thanks for listening to the RANE Insights podcast from RANE Network. Be sure to check out Dr. Mark Gold's full bio and host of written publications at psychologytoday.com. Want more RANE content? Find the RANE podcast series wherever you get your podcasts, or visit our website at ranenetwork.com. That's RANE network.com. Thanks for listening.